getting feedback from people. It's really lovely that they can just tune in for 45 minutes during a lunchtime without having to go anywhere. And it doesn't seem to be serving a really nice purpose, both educationally and also in terms of the interaction of us as a community of Barnet GPs. So really pleased that we continue to do this as a Pam Barnet event with the Training Hub and Anisha in particular for running them. So thank you very much. And with Anuj and the team from the Federation and ourselves from the Barnet Borough Commissioning. So the title today is More of Sharing and Learning in COVID, with a particular focus on paediatric experiences. I'm really pleased that we've got Dr. Krishnan Jada, who's paediatric consultant from Barnet, who really kindly has offered his time to speak to us and answer any questions. We've also got from Barnet Simon Brill, who was known to us. He's been on the last couple of calls. He's a respiratory consultant. And I'm not sure if you're here yet, Simon, but if you are, would you be happy just to give a 30-second update on where we are with the respiratory advice line? If you're here, thanks. Possibly he's not here yet. Okay, we can come back to that. Or I can actually flag that I had a chat with him that we're just trying to work out a single point of access, which makes it easier for us to call, and technicalities, but they're looking to get going as quickly as possible to support that. So we're talking about hopefully the next week or so. I'm aware that not all the locums get the bulletins that are coming from either NCL or from the Barnet Borough. We don't have access to the performers list as an anomaly of the GDPR regulation, so we're not allowed as commissioners to have the list of GPs. So if you don't get, or you know of somebody that's not getting the bulletin, can you put their email on the chat and we'll make sure that their name is forwarded on the circulation list. So that would be really helpful. Another plea is for those of you, for everyone who's engaged with work in care homes, there is the Care Home Supervision Project, which is run by Anisha. And if Anisha is able to put her email on there, could you flag if your care homes don't know? Could you ask them if they are cited on the support project, which is really, really helpful support supervision group for the care home staff. So can you flag that to them if they don't know that, please? And Anisha can put the details on the chat. So moving on next, Jo Young, who is our lead for paediatrics in the commissioning team, a GP known to most of you. She's going to update on the changes that are happening with paediatrics that affect us in the Barnet Borough. Many thanks.
Thanks so much, Charlotte. Thank you so much for asking me to speak today on behalf of NCL CCG as Children and Young People's Lead. Hanny's just putting up the slides. I think I've got -3 minutes to speak, and so I was just going to give a really brief overview of some of the very recent updates. Things are obviously changing at a rapid pace, and so it's really just to highlight some pointers. Happy to take questions or any emails afterwards if you wanted further clarification, really. Hanny, if you could go forward, that'd be great. So really, the focus on children and young people, as we all know, has been the unintended consequences of COVID. Really, the impact of children and families, their initial reduced presentations to A&E, needing to be signposted to come back out, to reconnect with primary care services and the community services. This has been a combination of confusion, fear in the community of catching COVID, associated with barriers to healthcare, which have hopefully starting to ease. There was initially quite significant rumours going around that GP surgeries were closed, that services were closed, and this has been further followed by the current and much more topical mixed messaging around returning to schools. So our general plea, as with probably will come through as the themes today as well, is communication, communication and communication. Just keeping in touch, encouraging patients to come and attend. So I just wanted to highlight 2 or 3 areas, 2 main areas around the RCGP guidance, a mention about our local services, and then a quick mention about shielding with regards to children and young people. So with regards to birth certification, hopefully this is starting to improve. It's certainly been widely publicised and supported that birth registration at GP practices should still continue, despite there being an initial closure birth certificates being issued. My understanding is that birth registration, birth certification at the local town hall Barnet services has reopened in the last 2 weeks, but they're dealing with backlog by date order from the beginning of COVID of starting to issue birth certificates. So in the meantime, it's about just registering the newborns without the birth certification. You should still be receiving your hospital birth notification data, and we're just encouraging a proactive approach to phoning patients up, supporting them through the process, the online registration, once you receive that hospital birth certificate, birth notification. So it's really whatever can be done through admin, through your DocMan team, through your medical assistant systems to support that really, and to flag if there are any issues. Around the 6 to 8 week newborn check, the RCP guidance has remained and has been reinstated, supported by the RCPCH and public health, that newborn checks should be face to face. So that's your 8 now. Trying to the way of getting around it with PPE and with minimising contact would be to roll that into a combined appointment where possible with childhood 8-week immunisations. So whether that be associated with some telephone pre-screening, some video consultations to highlight any issues beforehand and to minimise patient fear. And sometimes patients just need a bit of reassurance in order to come in and present, and they've been remarkably relieved, I think, when they have come in. And then there's moving on to word about our local services. There has been significant changes in our paediatric emergency services, as you're hopefully aware of already. Since the beginning of COVID, paediatrics at Barnet particularly, and also UCH, has been on temporary redirection, and that remains in place until further notice. Hanny, if you could swap to the next slide. So in terms of wider paediatric services across NCL, my understanding from the recent update is that North Mid has reopened, is open for A&E for paediatrics, and has recently reopened for inpatient paediatrics. Barnet, UCH, Whittington and the Royal Free are have just reopened, and then also just some signposting towards CAMHS mental health, that their inpatient CAMHS team has moved from GOS to the Whittington recently. So what remains in place are the new pathways for the CAMHS crisis hubs, and also much more integrated system-wide planning, which is going on behind the scenes to try and consolidate both CAMHS and paediatrics, particularly in this time where we're trying to encourage children back to school. Hanny, if you could move on. So this extensive support is going on. It's a collaborative partnership between Barnet Council, education, public health, the providers. We're particularly focusing on supporting the vulnerable children, families, send families to go back to school. And so it remains that only a small minority of children are not recommended to return to school, and significant social distancing measures are being put in place to re-engage the vulnerable groups. Thanks, Hanny. And so it was really just a quick pathway for my final slide on shielding. Shielding guidance for children and young people came out recently. I'll leave up, there's also the link for the RCPCH document with regards to it. And this was just a really nice pathway contributed by, put together by Connecting Care for Children over at the Northwest Paediatric team, around looking at helping encourage the decision making and supporting children back to school, and it's really just only those with the shielding letter who should be staying off. With the others, it's encouraging support if they have a family member. So over on the left, if you've got a family member who is shielding, then really it's talking through some of these the discussions around social distancing and whether that can be adhered to. In the middle pathway, it's about thinking about who else is vulnerable, and are there any pregnant women in the family. And then on the right-hand side, really, it's only the very vulnerable who should be absolutely staying off school. So even the children who are vulnerable, but in this category here on the right, can still mostly attend. And it's really talking through on a case-by-case basis, seeing what support's available and that we're able to put in place. There is extensive resources out there, and if you're having any difficulties at all with barriers, school, health, education, do message me, email me. We're trying to help and encourage this as much as possible. Thanks. I'll thank you so much. That's all from me. I will move on. Let's move on to Anuj, I think.
Thanks very much, Jo. I'm just going to update you on a few of the Federation activities and services, just to highlight what's been happening and what's available for the Federation. So, Hanny, could you put the slide deck up for me? So we're just going to run through some of the services and activities. So just a little bit of background in terms of the EAS. The EAS is still running. It's providing 48,000 appointments. Those are the times and the sites at present. And I'll show you a little bit about the activity. If you go to the next slide. So the current activity shows that we are slightly overperforming, and that's because of April and May, where the variance was very high compared to last year. But we're still on track to perform for the rest of the year. So we have about 48,900 appointments because of the winter pressures appointments. So please do book in to the EAS, because the activity is still happening. Next slide. The AAC clinic is still running out of Edgware, and the plan, although it's still to be completely confirmed, but the plan is that the hot clinics will continue over July. We're hoping that the times will stay the same. If there is a change, we will come back to all the practices and let you know. But the likelihood is that the timing will probably also stay the same. So again, any hot patients, please do refer them through to the AAC clinic. Next slide. The smoking cessation service is something we're doing with the local authority. So we have a smoking cessation advisor on a Tuesday, Thursday, Saturday. The remote-based consultations in Finchley, and we've used quite a lot, 195 appointments, and we're hoping that will continue and expand over time as well. The anti-coag service, so please do consider this, because we offer the near-patient testing with our pharmacists at the hubs, and it allows you to have the INRs put straight into your EMIS systems. So it's run from the 3 sites as mentioned, and there's quite a bit of capacity there. So please do feel free to book in any patient that you think may need monitoring. And the diabetes service, which was a DQuist, it's changed slightly. We've got a DSN that provides at the moment 1 clinic on a Saturday, reviewing patients and moving them on either back to the practice or the CLCH service. So that's our updates. I just wanted to mention the fact that there's a lot of work, and I know Charlotte's already mentioned around the recovery, but you know, there is a lot of work around access, the MDTs and the care homes. So you know, we are being involved in those, and if there is any feedback to provide, please do so as well. That's it from me. I'm going to pass you on to Krishna. I think it is Krishna Jadhav from Pediatrics at Barnet.
Hi, hello guys. I'm Krishna. I'm joined by my colleague here, Paul, who's the designated safeguarding lead for Borough of Barnet. It's really nice to meet you all today. So I'm just going to say a few words about COVID in children and our experience of dealing with the hyperinflammatory syndrome described in children. Not describing this as an expert, because as Joanna suggested, we were on divert, so we didn't see many children in the last 2 months, leave alone children with COVID. But we did see a couple of children who presented to us with possible MIS-C. And then hopefully we'll have some discussion on pathways into hospital post-COVID for children. So as we all know, COVID has not affected children to the same extent as it did adults. And even children who got COVID, more than 90% of them were asymptomatic or had only mild to moderate symptoms. And the most common among these symptoms were fever, sore throat, dry persistent cough. And GI symptoms seem to be particularly common in children more than adults. Symptoms such as vomiting, diarrhea, abdominal pain, for some reason. Under 19, it seems to have affected all children all age groups uniformly, with no significant sex differences, like it was noted in adults, where there seems to be slightly more male preponderance. And clinical manifestations were also less severe in children than in adults. Of all the age group, it looks like children under 1 year, from a large-scale case series of few thousands reported from China, it looks like children under 1 seem to be, if they're going to get affected, most severely affected. So quickly moving on to the couple of cases. The first case we came across was from March. An 8-year-old came with temperature of up to 40 for 5 days, persistent dry cough, sore throat, vomiting, and an erythematous rash all over the trunk. Quite miserable on examination. Blood pressure systolic was around 92. It's an 8-year-old, so slightly hypertensive, tachycardic with a heart rate of around 150 and delayed capsule for 3 seconds, with cracked and sore lips and non-purulent conjunctivitis. So the team thought it was probably a strep infection or an early toxic shock syndrome because of hypertension.
Krishna, sorry to interrupt. Is it possible to talk a bit louder, because it's quite hard to hear you? Is it possible to go a bit closer to the microphone or a bit louder? Sorry.
Sure. Thank you for pointing it out. Okay, I'll try to be a bit closer to the phone and shout as well. So the team thought this could be a strep infection or an early toxic shock or a Kawasaki. So we did what we do normally for children like this. So started them on antibiotics because they were hypertensive, gave some fluid bolus, did some swabs and blood culture, and admitted them. We got a dermatology review who thought it could be measles or a hypersensitivity reaction to some unknown pathogen. We discussed a child with the infectious disease and the PICU at St. Mary's who suggested to treat for Kawasaki with IVIG, increase the dose of antibiotics to high dose, and add clindamycin to cover for toxic shock. So we fluid resuscitated, did an echo locally, and did swabs. The swabs came back as positive for rhinovirus. COVID was negative, and the measles and mumps serology were pending, and throat swab grew group A strep. The initial bloods showed borderline anemia with a hemoglobin of 98, normal white cell count, but slightly raised platelets and low lymphocytes. CRP was significantly elevated at 267, and ESR was also raised at 33. Chest X-ray showed some peribronchial opacification with some pleural effusion. So we discussed with the infectious disease team and transferred to St. Mary's. In St. Mary's, the team gave them a second dose of IVIG because the child was still quite febrile. Went on to need some oxygen for low saturations. They continued oxygenation, and the child made a gradual recovery and was discharged for 2 weeks course of antibiotics. And we followed the child up after a few weeks. The child had raised platelets of 800, which sometimes we see in children with Kawasaki. Was positive for ASOT following a throat swab positive for group A strep. There was some peeling of skin over the extremities, low iron levels. A repeat echo was normal. There were no coronary aneurysms. And a follow-up telephone review recently suggested the child is completely recovered and was discharged. A second child, again, was 9-year-old, presented to NorthMed with headaches, abdominal pain, and vomiting for 2 weeks. Was seen and actually discharged following a CT head, but then presented 2 weeks later with new episodes of fever, vomiting, and dry cough. The bloods showed leukopenia, raised LFTs, the hepatitis screen was normal, all the imaging was normal, and all the swabs were normal. So the decision was made to admit the child, but because the whole of NCL was on divert, the child was then admitted to the inpatient pediatric ward in Great Ormond Street. In Great Ormond Street, the child quickly went on to need oxygen and had some respiratory distress, so was transferred to PICU. Was started on some non-invasive ventilation, but then required invasive ventilation and was ventilated for 5 days and needed some low-dose inotropic support. Multiple swabs, including saliva, nasopharyngeal, and including bronchoalveolar lavage when the child was tubed, was negative for COVID. CT chest suggested COVID-like pattern, extensive ground glass opacities, and consolidation. The child was treated with antibiotics for 2 weeks. This child had very high ferritin of nearly about 600 or something, raised D-dimers as well, and low fibrinogen and low white cell count. The inflammatory markers, surprisingly, in this child was quite low. CRP, I don't think, went beyond 20 or something, and ESR was quite low in single digits. So in terms of inflammation, was completely different to the first child, but shared some of the other features with the first child. So it just shows the wide spectrum of symptoms this condition presented with. So we thought both these kids had what is now defined as multisystem inflammatory syndrome of childhood, which is characterized by systemic hyperinflammation with fever and multisystem organ dysfunction, predominantly affecting the cardiovascular system. It's also got another name called pediatric multisystem inflammatory syndrome, temporally associated with SARS. There is some overlap between the symptoms seen in Kawasaki, which we are reasonably familiar with, toxic shock syndrome, but also some notable differences. It was quite interesting that despite having these cases in Italy, China, and in Europe, it was us in UK where we kind of saw a pattern and raised an alert, which NHS introduced in 24, and I think AskPCH came out on 27th of April. And then since then, people have been on the lookout for this, and there have been more reports. We're not sure if all of them are falling within this case definition, and people are over-reporting, because the symptoms, despite the case definition, can be attributed by a variety of other childhood conditions. But for what it's worth, the WHO quickly came up with this case definition, which is any child who's less than 19 years of age with fever greater than 3 days, with 2 or more of the following features, which is rash or non-purulent conjunctivitis, hypertension or shock, features of myocardial dysfunction noted through biochemical scanning or ECG, and some evidence of coagulation derangement and GI symptoms associated with elevated markers of inflammation, and no other obvious cause of infection or inflammation like sepsis or both staph or staph, and evidence of some COVID, either exposure to somebody who's confirmed COVID or a PCR test positive or serology positive. And this condition does not appear to be caused by the virus itself, but rather an immune-mediated response to the virus, because as shown in this graph, this is the number of cases going up and the number of cases being recorded and the cumulative caseload. It seems to lag behind the peak by about a month. And this also is consistent with the 2 cases we saw. They presented initially, which was thought of as a febrile illness, reassured and discharged, but they came back after a week or 2 with what looked like Kawasaki-like syndrome. So there's something about the immune response to a delayed immune response to the virus, which seems to be triggering this condition. It's also confirmed by the fact that most of these children who are treated for MIS-C are not swab positive, but they have antibody positive, IgG, which kind of is a slightly more delayed antibody response than IgM. So I've just chosen a couple of case series published, one in UK and one, because these are the largest case series. There are loads of smaller case series of 10 to 15 cases reported from all over the world. But this was one of the first case series reported from Imperial team by colleagues Mike Levine and Liz Whitaker. A series of 58 patients, 80% of them had some evidence of COVID infection. Median age was 9. When you contrast it with Kawasaki or toxic, which are slightly younger, between 2 to 5 years of age, slightly higher incidence in girls, and most of them were children from Black and other ethnic minorities, and most of them are previously healthy kids, and they all showed higher white cell count and fibrinogen and CRP, and a severe lymphopenia and thrombocytopenia during the acute phase with some anemia. And they described three patterns: either persistent fever with inflammation without the features of Kawasaki, or meeting the diagnostic criteria for Kawasaki, or just shock with temperature, which is more like a toxic shock syndrome-like picture. And only 26% were positive for PCR through swabs, and about 87% of them are positive for IgG, as described before. And almost 80% of them had evidence of previous COVID infection, or current or previous COVID infection. And fever seemed to be the most predominant symptom associated with other GI symptoms, as I mentioned before, either vomiting, abdominal pain, or diarrhea. And rash was also present in about half of these kids. And lab evaluation shows quite significantly elevated inflammatory response with CRP with a median of around 229 in all, and ferritin of about 600. And in the UK series, about 50% of them needed quite significant fluid resuscitation and inotropic support. And echocardiographic follow-up showed about 14% of them showing some early signs of coronary aneurysms, as we expect with Kawasaki. And this is the other case series published from America, recently published in the Journal of Gastroenterology, which suggested that GI symptoms seem to be a major presentation component of these kids, and which is quite relevant to us in primary care and secondary care, because we do see a lot of children with GI symptoms, with diarrhea, abdominal pain. Abdominal pain is a very common presentation associated with fever. And if this is a delayed response, and if we're going to start seeing kids soon, then we might have to be on the lookout for early presentation of these kids. And more than 80% of these kids had at least one GI symptom, including abdominal pain, vomiting, diarrhea, in that order. And these symptoms were accompanied by fever, which was present in all the children, and rash in about 2/3 of them. And as mentioned before, about 1/3 of them presented during the acute phase, only to be reassured and sent home to be returned again in about a week or 2 weeks with GI symptoms and symptoms of MIS-C. And all patients, 96.9%, 9% of kids in this series had previous or current COVID in the form of antibodies. And they also showed, as in the previous series, high ESR, high CRP, low albumin, and elevated transaminases, which we saw in the second child. And in the American case series, only I think a quarter of them received oxygen, and only one child was intubated. And there's a significant overlap, as mentioned before, with KD and shock syndrome, but there are some significant differences, mainly in terms of age group affected. It's quite slightly older group of children, 8 to 9 years of age, and great elevation of inflammatory markers such as CRP and ESR. So I guess in summary is we need to start looking for this as we go into recovery phase, because GI symptoms seem to be quite prominent. But if we say what is the most significant, from my experience, problem facing children with relation to COVID, I would still say it's the other things. I think children have paid a very heavy price trying to keep the adult population safe and healthy during the COVID crisis, due to a lot of reasons Joanna mentioned in her talk. We are particularly concerned with safeguarding. As we've documented, there is a significant reduction in ED attendances, the pressures, the toxic stress associated with lockdown and social isolation of families, increase in alcohol sales and other stress, and lack of regular contact with GPs, teachers, health visitors, and social workers. Children's vaccination programs have been disrupted. Children have been not been to schools. Access to education has been a problem, particularly the vulnerable groups, non-English speaking groups, or parents were not that engaged in the first place. Those children were even more at risk. Reduction in physical health due to lack of play opportunities, and also mental health due to lack of routine associated with school, particularly among adolescents and children with special needs, and children with learning difficulties like autism, ADHD, the lack of routine. So I think the balance of risk, in summary, while we did what we had to do to make space and release capacity for adults during the crisis, time now for us to reclaim the space back that our children need for being safe and healthy. And I think it's quite urgent. And I would actually like to request Joanna, in terms of, I know the return of emergency services and inpatient ward services to Barnet is still not confirmed 100%. And I don't know what take you made from a CCG perspective and what representations we've had in the NCL CAG to make this an urgent requirement for our children. I know the decision point is end of July, but I think it's a bit too late. I think the case is very clear. We need to make a case for reopening our ED and our ward in Barnet ASAP. Sorry, that's the end of my talk.
Anisha,
Anisha, yeah,
when you're ready, I'm happy to just give a response to that when you're ready.
Oh, brilliant! Yeah, no, please go ahead, Charlotte, and then you can hand over to Laura if that's okay.
Just want to thank you, Krishna. That was really interesting hearing. And as some of the chat on the side, we're not seeing that many presentations like you, or wondering whether they're presenting directly to A&E rather than coming through primary care. So it's really very interesting to hear that, taking those two particular presentations. So thank you. From the perspective of system restarting and where that's going to be, it's not happening at a CCG level. This is happening at wider level, partly London region and CAG, and this is commands and control. So this isn't, we're not making local commission. This is based on multi-provider complex discussions, and I know this was absolutely the focus of last week, and it's being discussed between the big providers. And we will hear what happens. We obviously give our steer to what we think we need for our population, but just to feed in, it isn't happening at NCL level. So I hope that that's helpful.
Thanks, Charlotte. So what we'll do now is if we hand over to Laura. Laura has a few more cases for us, and then we'll take some more questions at the end. Thanks, Laura.
Thank you very much, Anisha, and thanks Charlotte and the organisers for the opportunity to discuss and contribute here on this forum. And Krishna and Joe, those are really good and informative presentations. Thank you. I'll try and make this very short and sweet because I understand there's a lot of chat on the chat function. I know, Nick, you've mentioned about the anti-coag service. There's other questions about the smoking cessation, etc. So I'll try and zip through these as quick as possible. What have we been saying during the out of hours? We've looked at the May data and the top 5 of fever, rash and non-specific skin eruption.